welcome everyone. This is the unique CCTST Grand Rounds. We have a visiting scholar from Vanderbilt University who Dr. Huaman will introduce more formally, but just as a frame of reference, the CCTST has a case scholars program, which is for early career faculty to conduct research and have a career development phase leading into future grants. And so Dr. Isaacs is part of that program at Vanderbilt. And we, as the Case Scholars Program here in Cincinnati, are serving as hosts. So Moises, why don't you take it from there?
Yeah, thank you, Meg. Thank you all for joining today. It's a pleasure to introduce Dr. David Isaacs. Dr. Isaacs is Assistant Professor of Neurology in the Division of Movement Disorders at Vanderbilt University Medical Center, and Assistant Professor of Pediatrics in the Division of Child Neurology at the Children's Hospital at Vanderbilt as well. Dr. Isaacs obtained his Bachelor of Science from the University of Southern Indiana, his medical degree from Indiana University, and his Master of Public Health from Vanderbilt University. He then completed his Neurology Residency and Movement Disorders Fellowship at Vanderbilt. And clinically, Dr. Isaacs serves children, adolescents, and adults with tic disorders and serves as co-director of the Vanderbilt Center for Tourette Syndrome and other tic disorders. Dr. Isaacs' research focuses on sensory function in Tourette syndrome, assessed via self-reported questionnaires and neuropsychological assays, psychosocial factors influencing the clinical course of Tourette syndrome, and quality of life across the span of individuals with Tourette syndrome. Dr. Isaacs receives funding from the Tourette Association of America, Teva Pharmaceuticals, and the NIH National Institute of Neurological Disorders and Stroke. And Dr. Isaacs has been a Case Scholar at Vanderbilt and was recently awarded a K23. So congratulations, David. And we are very happy to have you visiting Cincinnati today and presenting at the CCTST Grand Rounds and CTSA National Visiting Scholars Program.
Thank you, Moises. I appreciate that. And Meg, the kind introduction and the opportunity to present. And I'm going to share my screen here. And everybody can see this okay? Okay. Yeah, so thanks to the Visiting Scholars Program and the UCCTSA and everyone for this opportunity to meet and for me to share a little bit of our work that we've been doing down here. So these are my disclosures, which Dr. Huaman mentioned, none of which I think will present a serious conflict of interest, but just to be transparent. And then this is the outline for today's talk. And as I mentioned to Chris at the beginning, but I'm happy to take questions throughout the presentation. So please feel free to unmute yourself and ask me questions throughout. There will be time for question and discussion at the end too, but happy to take them during the presentation. So before we start talking about the specific research, I just wanted to give a little bit of background about Tourette syndrome. And before we talk about that, we just need to clarify or give a definition for tics. And so tics are stereotyped movements, which would be motor tics, or sounds, which would be vocal tics, that involve discrete muscle groups. And this video from one of our movement disorders journals is just giving some examples of tics, many of which are more complex tics, but just to give you kind of a sense of some of the variety of what you might see. Another characteristic of tics is that they are usually suppressible, at least for brief periods of time, and they are often preceded by an uncomfortable sensation, which I'll talk a little bit more about later, but which we call a premonitory urge. This premonitory urge seems to be more appreciable, or at least people are more likely to self-report it as they grow older, although even younger children sometimes can indicate when a tic is about to happen, even if they struggle to articulate the quality or character of that sensation. We often divide tics into simple tics and complex tics. These are certainly, it's a bit of a spectrum, and sometimes it's very difficult to disentangle, but nonetheless, these are common descriptors you might see. And so when we talk about Tourette's syndrome and other types of tic disorders, these are clinical diagnoses based on the presence of tics. And so what I've listed here are the clinical criteria based on the Diagnostic and Statistical Manual, or DSM, the 5th edition, for the most common types of tic disorders that we would see. So Tourette's syndrome up here on the upper left, you meet criteria if an individual has 2 or more motor tics, at least 1 vocal tic. Those tics have been present for at least 1 year, and they started in childhood before age 18, and assuming that there's not another better explanation for the tic. If you only have motor tics, but you satisfy these other criteria, then you would meet criteria for what's called persistent or chronic motor tic disorder. If you only have vocal tics, it's persistent or chronic vocal tic disorder. And while these do have slightly different diagnostic criteria, we really think of these as being part of a single clinical continuum. So Tourette syndrome, chronic motor tic disorder, chronic vocal tic disorder, the evidence would suggest that in large part the biology and certainly the clinical management are the same across these disorders. And so throughout this talk, I will be talking about Tourette syndrome. A couple of times I may slip into saying chronic tic disorder, and I'm really referring to this group, this cluster of disorders here. If an individual that, for example, I see in clinic, in our pediatric clinic, who's 7 or 8, for example, and has had tics for a couple of months, obviously at that point, we don't yet know if they will continue to have tics a year out. And so we diagnose them with a provisional tic disorder. If I see that same individual back a year later and their tic has resolved within a year, then we would retrospectively diagnose them as a transient tic disorder. There is some interesting evidence coming out of several centers, but specifically WashU in St. Louis, that seems to indicate that we used to think that many people with transient tic disorder, that their tics just completely remitted. There is more data that many of those individuals may have some subtle ongoing tics or reemergence of tics later on. And so a lot of maybe in the past, what we would diagnose as transient tic disorder, and really many of them may actually still have a mild version of a persistent or chronic tic disorder, the data would suggest. Tourette syndrome and other persistent tic disorders are relatively common. Prevalence estimates vary between 0.6 to 1.6%, at least historically. This has kind of been the range. There was a publication from the CDC group that just came out last year that basically said, almost doubled this to say that as many as 1 in 50 children aged 5 to 14 have a persistent tic disorder. So again, likely more common than what we have previously traditionally thought. So Tourette's syndrome and other chronic tic disorders do have a general trajectory, a clinical trajectory that while not true for any individual person, does seem to be true on the whole when you look collectively what we often may see at a trend population level. And that is that tics often start between the ages of 4 and 8. There's certainly a lot of waxing and waning over a period of weeks and months, but there is a general trend to increasing severity of tics over the course of late childhood and into early adolescence. And then between the ages of 10 and 12, there's often a peak in the severity of the tics, followed by in mid and late adolescence, moving into the late teenage years and early 20s, there seems to be a gradual reduction in the severity of the tics. And I'll just mention that, because Tourette syndrome is defined by the presence of tics with onset in childhood, a lot of the historical research has predominantly focused on children, obviously very important. But more and more data has come to light in recent years that while there is an improvement in tics throughout adolescence, that actually the vast majority of people with Tourette syndrome continue to have tics as adults. So there was a recent review paper just from last year that said there is remission of tics in only about 10 to 20% of people. So meaning 80 to 90% will still have tics throughout adulthood, although for 2/3 of them, those tics aren't significantly bothersome. There's another third where they remain a significant impact on their quality of life. So again, while there is this continuation of some of the tics as adults for most people. The other important consideration in Tourette syndrome from a research perspective is its complexity. It is a broader phenotype than the diagnostic criteria would suggest. So we define tics based on the presence of define Tourette syndrome based on the presence of motor and vocal tics, but 90% of patients with Tourette syndrome have a co-occurring condition. In children, the two most common would be ADHD. Between 50 to 55% of children with ADHD, of Tourette syndrome will have ADHD. Roughly 50% of children and adolescents will have OCD or obsessive compulsive behaviors. But we also see a variety of other conditions as well, anxiety, sleep issues, rage. And it's important to note too that 60 to 65% of people have at least two of these co-occurring conditions. So it's really these elements of the phenotype under the water here, while maybe less visible and not always why people present to clinic, are really common, and they're an integral part of the phenotype and are important considering research and management. Beyond these, so I just wanted to highlight here, we're talking about tics, which is the clinical hallmark of Tourette syndrome, neuropsychiatric symptoms like ADHD and OCD and anxiety, which are very common. But what's also interesting in what has come to light in the past decade is that there's a physical health toll to having Tourette syndrome. So these are a number of different studies, many of which were conducted in large national registries, particularly in Northern Europe. And what these have shown is that relative to the general population, individuals with Tourette syndrome have a 4-fold greater risk of completing suicide, a 2.5-fold higher risk of substance-related death, a nearly 3-fold higher risk of obesity, 2-fold risks of type 2 diabetes, circulatory system diseases, and a nearly 2-fold higher risk of overall premature death from any cause. And the reasons for this are unclear. In the last slide, I talked about how prevalent various psychiatric diagnoses like ADHD, OCD, anxiety, depression, how prevalent they are in individuals with Tourette syndrome. And we know that mental and physical health are very tightly related. And so people who have higher mental health burden tend to have more physical health problems. So you could surmise that this maybe isn't that unsurprising. This is a group that has a lot of mental health problems, mental health diagnoses, and they have more premature death. But what's interesting is that this same study actually excluded people who had, in a subsequent analysis, individuals with comorbid ADHD, OCD, and substance abuse, 3 of the most common co-occurring conditions. And what they found was that people with tics still had an increased mortality risk relative to the general population. So it's really unclear what's driving this, but certainly an important area for further research. What I also wanted to show is that this is the study from this graphic here on the right is from this Brander et al. Paper, which looked at diagnostic codes based on people with a Tourette syndrome diagnosis or chronic tic disorder diagnosis in their electronic medical record. And what you can see is that you start to see some increase in the incidence of a cardiometabolic diagnosis even in childhood. So even as early as 9 and 10, these curves between those with Tourette syndrome or another chronic tic disorder and those without start to separate and diverge. And obviously they become wider with time. And so it's not even unique to adults, but we're starting to see some evidence of this divergence even in childhood. And so just as these last 2 slides on the overview of Tourette syndrome, I just wanted to kind of summarize a couple of things. Some of the translational challenges, given that obviously this is a translational focused group, some of the specific challenges are that Tourette syndrome, like so many of the disorders that all of us study across across medicine, it's a multifaceted phenotype, and so there are lots of different aspects, and it's also very heterogeneous. And so while I mentioned that 50 to 55% have ADHD, that means there's another 45 to 50% who do not have ADHD. And there's some evidence, for example, that the presence of co-occurring conditions may influence or dictate or at least inform kind of clinical management decisions. And so it's multifaceted, it's heterogeneous. And then there's also these various symptoms, tics notoriously, but also other symptoms wax and wane over a period of various timeframes, days and weeks, or even months, and over the course of development. And then we're dealing with symptoms that are often difficult or challenging to quantify. So the gold standard rating for a lot of these facets of Tourette syndrome are semi-structured clinical interviews. So for tics, for example, we would use what's called the Yale Global Tic Severity Scale, or YGTSS. While it's a good scale, obviously it focuses on the tics. And so there are scales for individual elements but in general, there's not a universally accepted measure of overall tic severity, and so or overall severity of Tourette syndrome, I should say. And so, an individual with perhaps mild tics but very severe ADHD, what would be their overall Tourette syndrome severity rating, right? So these are just some of the different translational challenges from a clinical translational and also just the research aspect. The other,
I think
yes,
there's a question in the chat. Do we
Yeah.
know what causes tics?
So that's a great question. I saw Dr. Wu was on. He's probably more capable of answering this than I am. But we know. So there's a couple of ways to tackle that question. I may just touch on it and leave some for the discussion at the end. We know that Tourette syndrome is highly hereditary. So there's a very significant risk of having Tourette syndrome if you have a first-degree family member who's affected. So we know genetics are a factor. We also know there's different environmental risk factors. So various perinatal insults in accumulation can increase your risk of developing Tourette syndrome. So in terms of causal etiology, there is some evidence, but that said, there have been large GWAS and these genetic studies that have identified some single nucleotide polymorphisms and other kind of genetic abnormalities. But they really, so far, we only can explain a fraction of the cases of people with Tourette syndrome. So there's a huge piece that we're missing here in terms of trying to solve the puzzle of the causes of Tourette syndrome. From a neuroanatomical and neurophysiological basis, we know different networks are involved, and so the canonical or kind of classical network is which I'll touch on very briefly, but is the corticostriatal-thalamocortical network, which is a network that's involved in movement. And we know this is abnormal in people with Tourette syndrome, and different nodes and different connections within this network seem to be different. But I may stop there and we can dig more into that. But so we know a lot of, we know some, but there's a much more we don't know about Tourette syndrome. And then about tics, we know some about the physiology and the networks that are involved there. Yeah, I hope that at least touches on that point, and we can that may be worth digging more into in the discussion later So a question that's been driving our group, and I know that there's been sort of an overall shift in many groups throughout the globe, is this kind of shift in how we think about Tourette syndrome. And so while Tourette syndrome is defined by the presence of tics in childhood, using these DSM-5 criteria, and kind of traditionally the focus has been how can we reduce the severity of tics in children with Tourette syndrome. But given some of the evidence that we've talked about, where many people continue to have tics as adults, with a third still having bothersome tics, 90% have co-occurring psychiatric diagnoses or disorders, which persist into adulthood. And then there's this physical health toll. And so the question, I think, is sort of shifting, or at least additional questions are being asked about how can we not only improve tics in childhood, but how can we improve the health, both physical and mental, as well as obviously their tics, in individuals with Tourette syndrome across the lifespan. And so this has kind of been a driving question in our own work here. And so I'm going to shift gears now to talk about really the title. So some of our work in looking at sensory function and sensory aspects of Tourette syndrome. And we've talked about tics, we've talked about neuropsychiatric symptoms and physical health. And so it may seem a bit of a secretary to jump and talk about sensory processing, but I'm going to hopefully give a justification for how those things might be linked. So there are three primary motivations for why I've been interested, and our group has been interested in studying sensory phenomena in Tourette syndrome. And the first is that sensation and movement are very tightly interconnected. We know this from a symptomatic standpoint, from a neurophysiological and neuroanatomical standpoint, that there's this tight relationship between movement, motor, and sensory functioning. And since Tourette syndrome is a movement disorder defined by tics, it would make sense that we would also want to perhaps to get a better understanding of it, look at the sensory piece of that. And so not surprisingly, other movement disorders, so for example, Parkinson's disease, dystonia, Huntington's disease, many other movement disorders while we focus on the movements, and many of the diagnostic criteria are based on movement abnormalities, there also often is a sensory symptom or sensory component to those syndromes and disorders. And so this is a wonderful article. If people are interested, this Patel et al. With Jankovic and Mark Hallett, looking at kind of the sensory aspects of some of these different movement disorders, which is really a great paper, great review. And I mentioned that there's this network interaction here too. And so I'm not going to spend a lot of time diving into this, but this someone was asking about, well, what causes tics? And this is that network, that corticostriathalamocortical network. And so in movement disorders, we often focus on these models of what's called the direct pathway, indirect pathway, and hyperdirect pathway, and how changes in these pathways lead to various clinical symptoms. But the main point I wanted to draw out here is that while we often focus, when we're in movement disorders context, at least, we often focus on these various networks and loops and subnetworks. I think what's often overlooked, which the Patel really draws out well here, is that sensory input plays a key role. It informs these networks, and so this sensory input really informs movement. And so that sensation is relayed into these networks via spinocerebellar tracts, via the dorsal column medial lemnistic tracts, and spinothalamic tracts. And so these are really intertwined. I mean, that's the primary point I wanted to drive home. A second motivation is that many people with Tourette syndrome experience emotional and social difficulties and various psychiatric symptoms, as we discussed. And we know from a broader pool of studies, not unique to Tourette syndrome, that sensory development influences emotional and social development. And so this is a nice article from Neuron, now about 9 years ago, by Silberis. And what's shown here, it's kind of a busy slide, but what I wanted to point out is this dotted line in the middle is birth, and at the bottom, the x-axis is chronology and age. And so everything to the right of the line is postnatal, and then everything to the left is prenatal. And then on the left, on the y-axis here, are various functional milestones divided by domain. So these are sensory motor milestones, communication, social-emotional, and cognitive milestones. And what you can see here is just that the earliest functional milestones are sensory and motor. So response to touch, response to pain, to light, various neuromotor motor movements, and all manifest in utero, so prenatally. And then obviously that sensory motor development continues, especially in infancy and early childhood, but precedes these precede a lot of these higher order functional milestones. And so there's a growing appreciation for the fact that sensory as well as motor systems are sort of the foundation or underpinning on which higher order milestones are attained or achieved. And so there were abnormalities, even subtle ones, in sensory and motor function. Could that have a cascade effect? Could that have various ramifications for subsequent development? And so thinking about Tourette syndrome as a neurodevelopmental disorder in which we know there's a high prevalence of various psychiatric manifestations and social abnormalities later in life, could these sensory abnormalities be playing a role, as well as motor abnormalities early in development?
Dr. Isaacs, there's another question in the chat on, do people experience tics when they sleep?
That's a great question. Yes, there have been a few groups that have done polysomnograms in individuals with Tourette syndrome, and tics have been during sleep. It's I couldn't tell you how common it is. It's something in clinic people often report. A parent or a bed partner will note that the individual can have tics in sleep. So it does come up clinically, and there's sleep study evidence to support that too. So other neurodevelopmental disorders in which there are various social and emotional difficulties or differences, we also see high rates of sensory dysfunction. And I just listed, this is a sampling of papers for different disorders in which there is some evidence for sensory dysfunction. So again, Tourette syndrome is not unique here in that many developmental disorders will manifest also sensory dysfunction. And so the last motivation which I kind of briefly alluded to, is just that sensory symptoms are common in clinic, and the most common sensory symptom that we talk about is the premonitory urge. And I briefly defined this earlier, but it's an unpleasant sensation that typically builds in the time, a second or so before a tick, and then when the tick is performed, the sensation tends to lessen. It's very common. Like I said before, it tends to become better articulated, or at least more clearly articulated, as people get older. So there's some studies saying that individuals 10 and older seem to be more reliable in reporting this, but even younger children can detect an urge. Importantly, it's distressing for a lot of people. So and for some, as many as 60%, the urge itself is even more distressing than the tick. And there are various ways it's described, and it depends a lot on the individual. And even within a given individual, someone may describe a premonitory urge a particular way in their eyes, around their eye ticks, and they have a different quality or different type of urge involving with a neck tick, for example. So it's not necessarily homogeneous within a given person. Each tick may have slightly different features with this premonitory urge. And actually, as I'm sure you all probably know, the group under Dr. Wu and Dr. Gilbert at UC has done a lot of the seminal work in understanding the physiology and some of the underlying networks that are involved in specifically ticks, but also in premonitory urge, and helping us understand the biology there that's giving rise to this. Another sensory aspect of Tourette syndrome that is not as widely studied, but is of great interest to us here, is sensory over-responsivity. And this is defined as an excessively intense and or prolonged response to environmental stimuli that most people, at least neurotypical individuals, would not consider aversive. And so I know that examples are probably more helpful than the definition, but this would be, someone might be very disturbed by noise from electronic appliance, or if there's a lot of sensory stimuli going on in an environment, even if it's background, it makes them anxious. This can be, being irritated by a tag on the back of one's clothing, or how the sock bands, the elastic bands on the top of a sock, how they fit or don't fit, or how they feel against someone's leg. So there are a variety of ways that this can manifest. And there, I will acknowledge too, there are different terms that have been used over the years. This is one that's becoming more popular in the past couple of years, but previously things like sensory hyperresponsivity or sensory overreactivity, other terms have been used, which has created a bit of ambiguity and confusion, but more and more groups are starting to use this term, and so we've adopted that. This is a clinical phenomenon, meaning it's something we measure using self-report, questionnaires and measures, or proxy report measures about how children and or adults respond to given stimuli. It's common in people with Tourette syndrome, and so as many as 50% of children and then 80% of adults followed in clinic will endorse some degree of sensory overresponsivity, and there's some evidence that it too is associated with a worse quality of life. And so these are some of the three reasons why we wanted to study, or why I had interest in studying sensory aspects of Tourette syndrome. Tourette syndrome is a movement disorder, and movement and sensation are linked. Tourette syndrome is a neurodevelopmental disorder, and we know that sensory function is critical to normal development. And then sensory symptoms are commonly described and endorsed in clinic. And so this was kind of what led us to do some more work in this area. And so this is a study we did a couple of years ago. And we recruited, this is adults with Tourette syndrome and other chronic tic disorders. And we stratified them based on if they have Tourette syndrome with or without OCD. And then we also recruited individuals with OCD without tics and healthy controls. And then we compared them on a measure that captures or indexes sensory overresponsivity. It's called a sensory gating inventory. And what we found was that all three of the patient groups, those with Tourette syndrome or another chronic tic disorder, with and without OCD, those with OCD without tics, all had significantly higher sensory overresponsivity. They endorsed more of being, bothered by these various kinds of sensory environmental stimuli that would often be background for most people, than the control group. And so, but between these three patient groups, there was no difference. There was no significance between the patient groups, but the patients groups, each of them had higher scores than the controls. And it was a pretty large difference, specifically within those with Tourette syndrome. And so this just confirmed, kind of what people were telling us, then had some evidence to back that this really is common certainly in adults with Tourette syndrome. What also followed was that this degree of sensory overresponsivity correlated with other key aspects of the Tourette syndrome phenotype. So these are just two scatter plots. On the left axis is a transformed version of the sensory overresponsivity scale. And then on the on the x-axis here, this is an OCD self-report measure, the dimensional obsessive compulsive scale, and this is an ADHD self-report measure. And what you can see is that there are these significant relationships actually across all of the groups in terms of the severity of OCD symptoms and ADHD symptoms, and the severity of the extent of sensory overresponsivity. And these were adjusted for some other covariates like age and sex. And what was surprising and is still perplexing to us is that we did not see a significant relationship with the severity of tics. I mentioned earlier the Yale Global Tic Severity Scale, the YGTSS, which is our gold standard for assessing tic severity. And so we did not see a significant relationship between the severity of tics based on this scale and the amount of sensory responsivity endorsed, which is a potential several reasons for that we think, but nonetheless interesting. So the sum of that kind of lead up, we're finally getting to the title, the focus of the talk, which is that some of the work, the EEG work we've been doing. So we know that the majority of adults with Tourette syndrome have sensory overresponsivity or report this. And we know from other studies that this does not seem to be due to differences in stimulus detection. And so there are a number of groups that have compared people with Tourette syndrome and people without Tourette syndrome on how well they can smell, touch, hear various stimuli and where their perceptual thresholds are. And there does not seem to be a difference, at least none has been shown to date. And so it doesn't seem like this sensory overresponsivity is occurring at the level of stimulus detection. There have been some other studies looking at a phenomenon called sensory gating, showing that sensory gating does seem to be impaired with people with Tourette syndrome. And so sensory gating is a preconscious or subconscious filtering of redundant stimuli. And the reason then that it has an evolutionary advantage or purpose is in doing this, the brain is able to focus or allocate resources to more novel information, right? If a stimulus is redundant, if it's repetitive, then it's less novel and so of less potential relevance. So that's the evolutionary thought why this might have evolved. But it's a complicated phenomenon, meaning that it seems to happen at multiple levels of stimulus processing. So it's not just a single physiologic process. There's kind of multiple layers to this with both bottom up and top down mechanisms. We do know, or it seems that the prefrontal cortex plays a key role in sensory gating, and the primary sensory cortices are clearly involved as well. And so I'm going to talk a little bit about how we experimentally assess for sensory gating, but just as a broad overview, the rough paradigm is that an individual is given two identical stimuli in rapid succession. So these stimuli, for example, using a tone, a simple auditory tone, and they might be separated by 500 milliseconds, 400 milliseconds, and so they're very close together. And what we see in the healthy state is that the brain's response to the second stimulus, an identical stimulus, is dampened. There's less neural response after the second stimulus compared to the first. And so that is evidence of sensory gating. That's a normal, appropriate response. But what we see based on some evidence in some prior studies in Tourette syndrome is that blunting of the second response is impaired. It's not blunted to the same degree as you would expect or as you see in healthy individuals. And what's also important is that there have been a couple of studies using functional imaging, which have shown that networks and abnormalities that we expect in Tourette syndrome that those same areas and regions seem to be abnormal or respond differently during a sensory gating paradigm. So this is kind of where there's several converging lines of evidence as to why sensory gating, impaired sensory gating, could be very relevant in Tourette syndrome. What we sought to do was to see if we could identify an EEG, an electroencephalogram signature of sensory over-responsivity. And the reason we wanted to use EEG was because while functional imaging is very powerful in terms of spatial resolution and spatial topography, the EEG provides better temporal resolution. And so we really wanted to see if that additional extra temporal resolution would be able to give us new information or novel information about what's going on in people with Tourette syndrome, and also that perhaps people who otherwise may have trouble lying in a scanner or being involved in a task in a scanner, that those individuals may be more feasible to do an EEG on those individuals rather than a fMRI or a MRS or a PET scan or things like that. So what we've done, and what we've been doing, is recruiting individuals with Tourette syndrome and other chronic tic disorders, as well as neurotypical individuals, to undergo clinical assessments as well as a sensory gating EEG paradigm. And this study is being done in adults, and we primarily chose adults for a few reasons. One of which was we wanted to initially recruit a more severe phenotype, and so people who are followed in our adult clinic are part of that 1/3 of individuals who tend to have more severe tics, and many of their other comorbid co-occurring conditions are also more severe. So we thought perhaps we'd be more likely to identify a difference, an EEG difference, if we looked in a more severe phenotype. The other was that our paradigm currently is relatively long. The EEG part takes about an hour and a half to 2 hours, plus the clinical assessments in a single visit. And so until we had optimized it, we wanted to do this in a group that maybe had a better attention span, and started with adults as well. This is we're using a biosemi system, a dense array 128 electrode EEG, and this is not one of our participants. This is from the biosemi website, but this is exactly what it looks like. This on the left is a schematic of the paradigm itself. And so we have a short practice block, and then 2 auditory blocks, and then 2 tactile blocks. So within the auditory block, what you would see is that these black dots represent stimuli. And so this is, I mentioned the tones earlier, and that's what we're using. We're using an auditory tone. It's about 65 decibels, roughly conversation level tone. It's a pure tone. It's 20 milliseconds in duration. So we give one, we wait 500 milliseconds. There's another one, and then there's a 7 to 7.5 second lag, and then another pair is presented. And this happens over and over and over. So we're collecting repeated trials. We also have embedded a simple reaction time task. So the participant is shown a plus sign or a cross on a screen, and they have to hit the space bar as fast as they can when they see that. And that is for 2 reasons. One, to promote attention towards the screen and away from the stimuli, and the other so we can quantify level of alertness and level of attention. So that's why that's embedded in there. And these are randomly interspersed throughout the tone pairs. So that's the auditory block. They get 90 pairs of these stimuli. For the tactile block, it's the exact same setup, with the only difference being that instead of a tone, it's a puff of air against the index finger, the tip of the non-dominant index finger. But every other aspect of the setup I just told you about is identical. And our primary interest in a method of analyzing and approaching this data is using time frequency analysis. And I know some of you may be intimately and are probably more familiar with this than I am, but I wanted to give a little bit of background for those people who may not have familiarity with EEG or time frequency analysis specifically. But what's shown up here on the right here is in this block A of this figure is just maybe what an output you would see from a single electrode over time. And so this is the amplitude of the signal, and this is the time duration here. And what you can do using various mathematical techniques is you can decompose this signal into various frequency bands. And the ranges for the frequency bands, there's some variability in how they're defined, but one of the common conventions is using these ranges. So for low frequency, delta range 1 to 4 hertz, theta, alpha, beta, gamma, going up the ladder here. And this might be what these are just some examples of what, a gamma band signal would look like, and theta and delta. And so what we actually do is we take this EEG signal, and for each trial, so I mentioned that, for example, the auditory block, there are 90 trials. So we would take that, we would do this decomposition for each of those 90 trials, and then you average it together. And there's several steps in this process, which I'm happy to go into later on. But doing it this way, so using single trial EEG and then average together, what that allows you is it's an advantage over an older technique that is still very helpful and can be used sometimes, called event-related potential analysis, or ERP. You're able to quantify and investigate activity that isn't totally, we say, phase locked. So the timing of it isn't, and that's what this figure is trying to show. If you look at this signal here, this is there's a stimulus here right at the beginning of this bar, and then there's a brain response, which is captured by the EEG. You average that and you say, okay, well, this is the brain's response across all of these trials, and that looks good and very clean. What we sometimes see, though, is that perhaps some activity may be very tightly phase locked to a stimulus, or occur very precisely at a certain time window. Other activity may not be so tightly time locked, and so you're getting a very similar signal here, but it's shifted by perhaps 50, 10, 20 milliseconds. And what happens is when you average these together, then you end up getting some cancellation of your signal. And so you may look at this and say, well, okay, there wasn't much of a brain response, when in fact, if you could look at the individual EEG trial data, single trial data, you would see that the amplitude of the response is very similar. It's just not phase locked. So that's what single trial EEG using time frequency analysis gets you, is it allows you to sort of have a different perspective of some of that non-phase locked activity, which is what we're interested in. And so these are time frequency maps, some output from our preliminary data. So what I'm showing is data from 14 adults with chronic tic disorder, and you'll see that it says CTD in the upper right of the subplot, and then healthy controls, which is denoted by HC here. And just to kind of orient those of you who may not be familiar with these plots, on the x-axis again is time in milliseconds. These are frequency distributions here on the y-axis. The arrows are the stimulus, when the stimulus occurs, and this specifically is for our auditory tasks. So these are tones. And what you can, and then I've got it broken down into the yellow box would be what we would typically consider alpha band activity, the blue would be beta, and then the red is gamma. And then less than this would be delta theta down here. What you can see is that after the first stimulus, there's a lot of low frequency activity. There's a very high amount of power in the low frequency ranges. And I should, also clarify, warmer colors are higher power, which means roughly higher amplitude, and then cooler colors would be lower power. And what you can see then is after the second stimulus, there is, almost absent, certainly a significant reduction in the amount of neural activity in these low frequencies. So what that's telling us is this is exactly sensory gating. So same stimulus, identical stimulus, 500, 400, 500 milliseconds apart, but you don't see that low frequency hotspot that you saw after the first stimulus. And we see that actually in both groups. So both the controls and the individuals with chronic tic disorder, there seems to be effective gating, which would at first blush seem to kind of undermine our hypothesis. But what I want to draw your attention to is in this beta range, is in this alpha region. And there's some studies showing that the alpha band in particular is important for auditory gating. And what you can see is that in preceding and immediately following the second stimulus, that there seems to be, at least visually, a difference in the amount of alpha power. And this did not reach statistical significance in this pilot sample. But what's interesting is that if we look within our sample, what we see is that this is within the Tourette syndrome sample, that there's actually a tight correlation between the degree of sensory gating based on this EEG measure and what patients are self-reporting, participants are self-reporting in their sensory over-responsivity score. So this at least we think is promising that there is some relationship between these EEG indices, what we're trying to capture, and the actual clinical phenomenon that patients are reporting, the symptom itself. And so I'm going to talk in just 2 more slides about our current enrollment, because we've now actually doubled our sample size, and we're currently processing these this next wave of data. And so we're anticipating that some of these differences will become statistically significant, and I'll be very curious to see if this correlation is still evident in that larger cohort. These are the plots for our tactile paradigm. And so again, now this arrow represents a puff, and it's a little bit more striking here. And in fact, there are some statistically significant differences in the gamma range on this paradigm. So even in this pilot smaller sample, we did start to see significant differences. But specifically in the beta and gamma range, the difference is here as opposed to in the alpha, like it was in the auditory, which we know that beta and gamma activity in different regions of the brain and in different networks are abnormal in other kinds of movement disorders, including Tourette syndrome in the motor cortex, including Parkinson's disease and things like the subthalamic nucleus. So it's not unexpected that different frequency bands may be relevant for different types of stimuli. And so this is kind of what I was just showing you, that at least in the gamma range, we actually see some significant differences already, and then there's a trend towards that in some of the beta activity, although it did not reach significance in our pilot sample. And so this is I have this slide and one more slide, and then I would love to have questions and discussion, or I can go back to any elements if I rushed through anything too quickly. But so as I mentioned, we've over doubled our sample size now. So we've got data for 31 individuals with Tourette syndrome and 27 controls for auditory paradigm. We had a couple of technical malfunctions on our tactile paradigm, so we have a little bit, 1 or 2 less participants over here, but we've increased our sample size. So we're currently analyzing that data. We're very interested in understanding the between group contrasts in terms of the power, but we're also very interested in things like the phase locking indices and making sure we're accounting for the presence of comorbid conditions and medication status. And we have a lot of additional extensions of this work that we'd like to pursue, including recruiting adolescents, doing more of a longitudinal evaluation. So repeating the same assessment, a year or 2 later, or following introduction of a medication or a treatment. So this is some other work that is in planning stages currently. And I really just wanted to thank we have a great team down here, and it would certainly not be possible without their help, particularly Michelle Eklund, who's our research coordinator, who's done so much work. Daniel Clausen, who's my primary mentor, and then Alex Conley, who built all of the MATLAB pipelines that we use for our EEG signal processing. So, so I'm very grateful for their invaluable help. And I think with that, I will stop. And I hope I left enough time for some questions here.
There's definitely time for questions.
Okay, great. Maybe I can read a couple of the chat.
If you start from the bottom in the chat, that I think is the best way to go. There's one from Ashita.
I can ask my questions.
Thank
I
you.
was just writing them in the chat so that I don't forget. So I actually had a couple questions from your slides. So the first one was there a specific reason why you chose to have like consecutive tactile blocks instead of alternating between your consecutive auditory blocks instead of alternating between auditory and tactile, so that you don't get like over habituation? That was my first question. And the second one was, which EEG channels are you particularly looking at, or if you have a way of selecting channels, or even are you looking at source localizations and things like that?
Yeah. So to your first question, actually, I'll go back here. That the we didn't alternate. So there is we did put there's a jitter here, which may not be evident from this, but there's a random jitter. It's the time between pairs is 7 to 7.5 seconds, partly to try to address that concern you mentioned about the over habituation. We are actually you bring up a great point, because so we are interested in understanding, for example, if you had concurrent auditory and tactile stimuli, at the same exact moment or shortly after each other, it's kind of a multisensory type of paradigm, would you see similar or more profound effects or differences? That's actually we were just talking about this last week. But as to why we didn't alternate auditory and tactile, I think I just didn't think about that. But that would be interesting. Yeah. So we'd set up as a mono, and we tried to address the habituation by having a little bit of jitter in here in these random reaction times tasks. Your other question, Ishita, so we're not doing source localization currently, at least that's not, we are using, like, for our time frequency, we're using like the electrode as the, that's the topology we're using. We're not kind of doing a source modeling and then using the modeled point as kind of our basis for doing time frequency. And then, what you asked about specific electrodes or regions of interest. Yeah, so we're primarily interested in the frontal, mainly because of the prefrontal cortex, because of some studies. So there's another paradigm called a prepulse inhibition, where basically a puff of air is applied to usually the outer part of the eye, and then you measure kind of the blink response. And in studies using that approach, there does seem to be that the prefrontal cortex is involved or changes its activity level in response. And so from kind of applying that knowledge from other healthy individuals and other disorders, we were interested in the prefrontal cortex specifically. And so we're using a frontal ROI, region of interest. So those were preset. We're not doing an empirical clustering of electrodes, although we've talked about that. But for now, we wanted to really look at the preset defined regions. And then we're also looking at the parietal region, parietal for the tactile, and then the temporal for the auditory, just given the underlying associated cortices.
You're recording from 128 channels, right? So it's kind of covering the whole head. So that's why I was wondering why. I'm assuming you wouldn't be throwing out like the rest of the data.
No, we're still keeping it. Our analyses have focused on these regions of interest, but yeah, we still have that data, and so that's, yeah.
This in a very pilot study with MEG. So that was my another question. We actually saw this was a completely different paradigm with the chirp signal. We were trying to see if kids with Fragile X can follow the chirp compared to healthy controls, and it looked like it was mostly the temporal cortices that were involved. But again, with EEGs, due to how the signals fold, they might end up being in the frontal channels. But yeah, so my last question was, in future, do you envision doing like MEGs, for example, with a similar paradigm?
Yeah, no, it's a great question. I haven't thought about that. Yeah, no, I think that would be cool. I have no experience with MEG, so I'm obviously
it's very rarely done, but I think they have much better signal to noise ratio than EEGs in general, especially for sensory processing, I think. But yeah, I mean, I just thought about that because at Children's, I think there was a group who was doing that, and yeah.
That's interesting. No, I think that would be cool. Those are great questions.
One other question in the chat. Do your EEG measures correlate with any clinical scales? YG, TSS, and PUT?
We not with those specific scales. the EEG measured, that's a great question, does correlate with the sensory over-responsivity scale, which isn't necessarily, but it did not correlate with like tic severity on the YGTSS or premonitory urge. What was interesting, I didn't talk about this, but in another paper, we had looked at, do sensory over-responsivity as people report it, and then the premonitory urge using the puts, which Dr. Wu mentioned. And there's a weak correlation, but it's not very strong, and which was kind of surprising to us. We thought they would really overlap a lot, but which to us suggested that maybe these really are related but distinct phenomena, and involve different networks. But
hey, David, it's Steve Wu over at Children's. Great talk. So one potential explanations for many kids getting better as they age is an issue of adaptation. And so looking at your data set, I wonder if you've looked at the beginning of the auditory task versus as time goes on towards the latter part of your auditory blocks, and also applying to the tactile condition as well. Because I wonder, as they get more and more stimulus, eventually towards the end of the experiment, if the brain response is going to be different.
no, that's a great point. We have not looked at that yet, but I will say one other challenge has just been so there are studies in healthy individuals showing that attention matters a lot in sensory gating, which again is part of why we embedded that reaction time task. And I will say that it does seem like people's reaction time slows over the course of the experiment, which I think everybody would probably predict. And so when we do our analysis, we are planning to factor in their attention, but we've not looked at the various blocks, and how it might change over the course of so that's a great point.
Well, I think you've masterfully filled your full hour and kept us all interested in the work that you're doing, David. So thank you very much for visiting with us.